Good morning to you all. Is it afternoon? Hello.
Good afternoon, sir.
Good afternoon. How are you?
We are doing well, you.
Yeah, doing well.
We thank God.
And you?
Okay. So last week we spoke about a lot of conditions, and this week we're going to continue, so we can finish on time and move on to another condition. So last week we treated assessment, where we started with assessment of musculoskeletal disorders. We move on to bursitis and tendinitis. I showed you pictures on that. Then we moved on to dislocation of shoulders and joints. We discussed descriptions and causes, signs and symptoms. I showed you pictures. Shoulder joints always getting dislocated. And if you can manage it well with the bandages and then the arm's length, you do that. So we talk about fractures, femoral fracture, and then I think gout, fracture of the hip, we did that, and we ended at gouty and gouty arthritis. So today we want to look at gout. This condition affects, initially it was affecting the elderly and then the aged due to accumulated effects of bad dieting or bad eating practices. But recently, the youth are also being affected as a result of the same lifestyle factors, such as bad eating and bad habit. So it's an inflammatory arthritis, but this inflammation is caused by uric acid crystal deposits. So uric acid crystal deposit will trigger an immune response. And once the immune response is triggered, then it leads to the inflammatory process. So how will the crystal deposit or the uric acid crystal deposit be generated from? So this uric acid crystal deposit is in the blood, and the precipitate behaves like when you have written on the blackboard and then the chalk, the small powdered chalk. That is how the crystal deposit looks like. So this deposit builds within the blood and accumulates in connective tissues. So it could be deposited at the joint, it could be deposited at the bones, and so forth. So once it builds up, the connective tissue builds up. These are uric acid crystals that has been generated as a result of bad eating habits or as a result of genetic disorder. We will look at how the uric acid gets generated. But this uric acid gets generated, deposited at the connective tissue, and form an accumulation like a node within the connective tissues. It is called tophi. So this tophi is deposited over a period after it builds up gradually at various joints and the various connective tissues. And this disorder is characterized by reddish area. So the area looks reddish, looks swollen, and so painful. These are the three things that marks the condition: redness, swelling, and painful joints as a result of uric acid crystal deposit at the various connective tissue. So the uric acid crystal deposit, so this is one of the pictures of the gouty arthritis. Here it is at the big toe. So the picture makes you remember the signs here that it looks reddish and goes along with pain and then swelling because of the inflammation. So it has all the inflammatory signs and symptoms. So here, you see, it pains you so much at the various joints. So these are the signs that is describing the condition. And that is the swelling at the joints, the nodes. We call them nodes. So we talk about the nodes. The one you see swelling called the nodes, Heberden's nose and the Bucker's nose. They are the two main nodes. We look at the two main nodes, Bucker's nose and Heberden's nose. So these are swellings that characterizes the condition, and they are called the Heberden's nose and other Bucas nose. So look at the various nose as we move on. So here we are saying that the acutely painful joint mostly affects the feet. So that is where I show you the diagram. It affects the great toe or the big toe, the ankle, and then the midfoot. So the condition affects these areas. Once it is struck, it peaks suddenly and the pain becomes so severe. The patient may remain symptom-free for years between attacks. So over the years, you may not show any signs and symptoms, or the symptoms come and go, and then on and off like that, until suddenly when it strikes suddenly and picks up quickly, then there is no remission at all. So it takes time for the tophi to accumulate from precipitate of these uric acids. So we will finally look at how does the uric acid get produced or get generated within the body. So this is one of the diagrams of the areas where gouty arthritis occur. So here we have chronic polyarticular gout. Here, the final unremitting state of the disease. So it starts affecting one joint, and as the condition progresses, if you don't put brakes on it, then more joints are affected. More joints are affected. So here you will see that the condition affects one big toe. Then if you don't manage and stop the bad habit, then it keeps involving or bringing together other joints. Then you have polyarticular gout. That is the final unremitting state of the disease, and it's marked by persistent, painful polyarticular arthritis. So here there is more joints involved. The pain is so severe and becomes chronic. So the main cause of the primary gout, so we have primary gout and then secondary gout. But the main cause of the primary gout include decreased renal excretion. So here it may range from, or it may come from the fact that as you accumulate the uric acid, you don't take so much water or you don't take so much fluid to increase urine production, so that as the urine is being produced, uric acid is excreted so that it may get rid out of the body. So if you are the person who takes less water or who don't like taking water, this is the reason why uric acid gets accumulated within the body. So it's either decreased renal excretion of uric acid because you don't take enough fluids or flush the body from these accumulated uric acids, or there is an over secretion of uric acid. And this comes from a genetic defect in some people who have abnormal purine metabolism. So there's a defect in certain people. They lack a certain genetic factor that makes sure that purine is metabolized completely. And purine is one of the proteins that is generated within the body. It's a protein source, and the body must metabolize them completely. Some people have genetic defects, and those who have genetic defects cannot metabolize purine completely. And if purine is not metabolized completely, it accumulates a lot of these harmful effects called uric acids. So it leads to a condition called hyperuricemia, which is excessive accumulation of uric acid crystals as a result of defective in purine metabolism. So you can inherit this disorder, and this condition can run in families. At a certain family, at a certain point, everybody starts getting painful joint. Everybody starts getting waist pains. Everybody starts complaining of ankle joint pains here and there. It is as a result of the family line who inherit this genetic effect from one parent to the other, from one generation to the other generation. So you will see that there's that defective gene that leads to abnormal in purine metabolism, leading to hyperuricemia. So the major two causes of this condition, uric acid accumulation in the body that builds the tophi, is as a result of either there's decreased excretion or there's increased production or increased accumulation of uric acid crystals in the body. So radical dieting practices that involve starvation. Some people, they fast so much, they don't take enough water to flush the system. And as you starve, you are starving with your body is producing waste products, and you are not taking enough water to flush them out. So the waste will be accumulated. And one of the major waste here is uric acid. A diet high in red organ meat. Some people like taking so much meat, especially the guys. You like taking so much meat. And we are warning you from this course that if you are the type who like taking red organ meat or red meat, then be careful, you are accumulating a lot of uric acid crystals. And finally, it may lead to tophi accumulation and joint pain. Seafoods, or high fructose corn syrup. These are foods that are high in uric acid crystal. So once you take in this food, it leads to accumulation of these uric acid crystals. Then we have high alcohol consumption, especially beer. If you are the one who likes taking so much beer, be careful, because once you take so much meat, the red meat, and you take beer in addition, you are building up tophi gradually over the years. Then we talk about secondary gout. We've already dealt with primary gout, and I've told you about the causes of primary gout. We are saying that primary gout is the one that is being produced from genetic defect of purine metabolism. As you inherit genetic defect and you are not able to metabolize purine completely, then there is this purine that is being abnormally metabolized, leading to uric acid accumulation. Or you don't take enough water, and therefore there's decreased excretion of uric acid from the body. And this accumulates and form a substance like tophi, and that leads to the inflammatory process as a result of immune response. You know, the tophi accumulation behaves like a foreign body in the body. Once the foreign body is built up as a result of the tophi accumulation, the body reacts to the foreign body, which is the tophi, as a foreign substance, and therefore it releases the immune responses. This immune response leads to inflammatory process. That is how the condition occurs. Then we have a secondary gout, which is certainly coming from taking of medications such as thiazide diuretics, such as cyclosporin, diabetic mellitus, hypertension, leukopenia, myeloma, truncal obesity, polycythemia, renal diseases, and hypercholesterolemia. These conditions are classified as secondary gout because once you suffer from any one or more of these conditions, you are more likely to experience gouty arthritis. Primary gout is more common in men than women because of the habits, the lifestyle we built over the years. So primary gout normally is associated with the males because we like taking beer, we like taking red meat, and we sit in the evening to gather around and take beer and meat. So our lifestyle predisposes the men more to this condition than the women as their counterparts. So the condition occurs between the ages of 30 and 60. At this age, you have built so much capacity, you have money in your pocket, you are working, and therefore you can buy what you want to buy, you can eat whatever you want to eat, you have so much money, and you can describe whatever meat you want to take. Your food should be preoccupied with so much meat, and therefore you start building the tophi gradually within the joints. So the onset of the condition is normally related to the age range of 30 and 60. That is within the working age group where you are very active with so much money in your pocket. Complications include, so once you get the problem or once you develop the gouty arthritis, one of the complications here is renal calculi. Here it is the tophi that has formed something like a stone as a result of accumulated deposit of these uric acid crystals. So if there's gradual deposition, it keeps accumulating, and forms something like a stone. So once the stone is formed, it leads to this renal calculi, especially if it forms within the renal system. Then as the urine is formed and the urine is being produced, the stone moves gradually because the urine is moving the stones, and that goes along with so much pain. Renal calculi, you cannot bear the pain, and they take the person straight forward to surgery for surgical intervention to remove the stones. If you have witnessed one before, you'll be shocked that they can remove as heavy as stones from the body and from the renal system, and they keep it at the lab for investigations. So this condition can lead to renal calculi. It can also lead to atherosclerotic diseases. Cardiovascular lesions can also occur. The neuropathies can also occur from this particular condition. Then the signs and symptoms here, we look at an acute attack appears suddenly and peak quickly. I've told you that it takes time to occur, but once it occurs, it runs like Usain Bolt. The condition runs very, very fast once it starts. Initially, one or more few joints are affected with much pain signs and symptoms like pain, redness, tenderness, and warmth. And inflammation at the affected joints. There's low-grade fever, which can also occur. So this low-grade fever is coming from the point of inflammation, you understand. And few joints are affected initially, but as the condition progresses, more joints are involved. Symptoms may subside quickly, but tend to occur at irregular intervals. So at irregular intervals, you may experience the signs and symptoms of the condition. Severe attacks can persist for days or weeks. So once it occurs, it can persist for days or weeks. And sometimes the timing of the condition is very irregular. You cannot time it. It occurs at time you cannot be sure that it has occurred. In later stages of the disease, after polyarthritis, gout has developed. Polyarthritis develops in multiple joints and subcutaneous tophi. So here, the multiple joints means more joints are involved, and the subcutaneously, the tophi has also developed. That is urate crystal deposit. That's the tophi, which can occur at the subcutaneous area and also the joints. The skin over the tophi may ulcerate. So the skin that under which the tophi has developed may ulcerate because of the inflammatory process. The immune response leads to inflammation, and over the skin, the area looks reddish, looks swollen, and looks painful. And those are the signs of inflammation. So the affected skin becomes ulcerate or start to ulcerate and release a chalky white exudate or pus. And that is where the condition becomes very, very severe. Once it ulcerates, it means some kind of wound has occurred there. And you see a release of chalky white exudate or pus coming from the ulcerated area. So in diagnosis, we look at serum uric acid levels and WBC counts, and going to be elevated because of the inflammatory process. So during an acute attack or gouty attack, urine uric acid levels are chronically to be elevated. About 20% of patients will have an elevated uric acid levels. Once you take X-ray at the joint, the articular cartilages and the subchondral bone shows evidence of chronic gout. So evidence from X-ray will show that really there has been an inflammation at the joint. Needle aspiration of synovial fluid shows needle-like intracellular crystals and elevated WBC counts. Treatment aims to bring acute attacks under control. So once you are treating the patient, your main aim is to bring the acute attack under control. There's no need keeping the patient in so much severe pains. So everything you need to do is to make sure that the patient gets relief. The patient gets relief from the pains. The patient gets relief. So whatever you may do to reduce the pains, do it. Make sure that the patient is free from pains because the condition is marked with severe pains. So here, once you start treatment, you are aiming to bring the pain under control, reduce the hyperuricemia, which is the primary cause of the disease, and prevent future complications. That is the three main aim for treatment of gouty arthritis. Bringing the severe acute attacks under control, reduce hyperuricemia, and prevent complications. So here, dietary restrictions include avoiding alcohol. I've told you, especially the beer. Once you like taking beer, then combine with the meat that the red meat that you take, in primary or in SS, if you talk about metabolism of proteins, especially meat, then you know that there is a procedure called deamination. And deamination takes place within the liver. The liver metabolizes the meat that you take or proteins that you take, and therefore leads to the waste products such as urea, uric acid, and crystals, and then ammonia. These ones are also part of the process here. Once you like taking red meat, and therefore there's metabolism, it leads to a lot of uric acid accumulation. And if you are not taking enough water to flush the uric acid accumulated, it keeps on building up and becomes the tophi. And once the tophi forms, the body reacts to the tophi by releasing immune responses to fight the tophi. And that leads to the inflammatory process. That leads to the inflammatory process. So avoid alcohol, eating pure or purine rich. So here you have to avoid eating purine rich foods. And those are such as anchovies, liver, sardines. Some people like taking sardine when they want to take biehu and then a mutio, definitely they'll have to invite sardine. So meat is preoccupied with your food. You cannot see the food unless you put the meat aside. And these are bad practices. We are telling you, once you are aging, there's no need taking so much meat. If you take so much meat, you are burdening the kidney, you are burdening your product with, or the system with uric acid tophi. You are predisposing yourself to gouty arthritis. Once you age, you are not supposed to take so much meat. So take notes. Leave the meat for the ladies and then the young ones. So those who don't like taking enough fluids, please, we advise to increase fluid intake during acute attacks. Then you manage with NSAIDs, non-steroidal anti-inflammatory drugs, to reduce the inflammation and then the pain. So you can take indomethacin, indocin, popularly known as akokrabobobo. So this, if you go to the village, the villagers, they are addicted to this drug. Go and buy me akokrabobobo. Go and buy me. So that's indomethacin. It is a form of NSAID for severe pains. So colchicine, it helps to stop the acute attacks. Colchicine is very, very effective. Then corticosteroids, because of the inflammatory process. Corticosteroids are known to be an anti-inflammatory and can be used to manage the inflammation. Allopurinol. Then we have the fibrosol-stat, probenecid, and sulfapirazone are used to treat the chronic gout. These medications are very effective when the condition goes into the chronic stage. They use these medications to manage them. Then how do you intervene? By the use of the nursing skills. So here we have to make sure that there's bed rest, total bed rest during the initial phases where the attack is acute. Then you focus on resting the affected joint. Don't use the joint to cause more inflammation. So rest the joint, rest the body, and make sure that you don't cause more joints to be inflamed. The use of bed cradle. Bed cradle will lift the bed close from the affected joint so you don't experience any pains. If appropriate, to prevent irritation and add pressure on the affected area, so the bed cradle will lift the weight of the gloves, the top gloves, from the affected area. Administer prescribed drugs. These drugs include colchicine within 24 hours of the onset of an acute attack. So colchicine is mostly used in the acute stages and is very effective in managing acute attacks of the condition. So you need to give comfort measures, give pain relief if the patient needs it as much as possible. Under no circumstance should you allow your patient to go through pains. Do everything possible to make the patient reduce the pain that they go through. If the patient can tolerate, then give it. Encourage liberal fluid intake to flush and increase the excretion of the uric acid. Then work with the patient to identify techniques and activities that promote rest and relaxation. So you are the nurse to do all these to make sure the patient achieves maximum comfort as much as possible. So dietary recommendations, because we said poor dieting can bring about the condition, then we need to be careful with our diet. So we need to give dietary recommendations. And we need to review the patient's diet history. Are they containing high purine foods? Help the patient select appropriate food that are free from purine-rich foods or purine sources. Provide low purine diet. Monitor the patient's serum uric acid levels and fluid balance, including intake and outtake. Teach the patient and family about the disorder and its treatment and provide support as much as possible. So here you need to include the patients and their family in the teaching of the condition and how they can best support their client at home. So is there any question here? Then we move on to lower back pain, gouty arthritis. Do you have any questions? Else we move on to lower back pain. Yes, Jennifer. Jennifer.
Sir,
Yes, let's hear.
please, I met a senior colleague during my service time. She was very fat, so she switched to keto. That's taking only proteins, only meat. He didn't take any carbohydrate food, only vegetables, and then protein was what he was eating. But you could see a massive change. She was able to slim very well. So I want to find out, is it good to do that, depending only on carbohydrates and then vegetables? Thank you.
So here you are talking about something different. The patient was heavy, was overweight as a result of carbohydrate food intake. You know, carbohydrate will make you heavy. And once you want to reduce weight, you cut off your carbohydrates, then you be on vegetables. The protein that she takes, maybe she takes a lot of water to flush the uric acids. How do you know? Maybe that patient is not prone to genetic defect or purine metabolism, and therefore she doesn't accumulate a lot of uric acid. And as much she takes water to also flush the accumulated uric acids. Definitely there will be no signs of gouty arthritis, and she'll be able to manage the weight well because she is not producing a lot of calories. It's the calories that put you at a very disadvantaged position of gaining weight. But once you cut off your calories and you make sure that you take only vitamins and proteins, why not? But these proteins are not proteins that are going to accumulate to give you more uric acids. Of course, you remember the primary cause of the condition. It is as a result of reduced excretion. So once you take enough fluid, you increase excretion and then you don't accumulate the uric acid to form tophi. So the lady might be doing that. And also she may not have the genetic defect to produce or to cause abnormal purine metabolism. So these are the two things. The lady can be free from uric acid even though she's on only protein and vitamins or vegetables. I hope it's clear. Joseph, I think I see Joseph hands up. Joseph.
Yes, sir. Please, I want to know whether there's a relation between ganglion cyst and rheumatoid arthritis.
What?
Is there a relation between ganglion cyst and rheumatoid arthritis?
Is it related to what we are learning right now?
Yes, please.
Have you mentioned rheumatoid arthritis?
Hey, sorry, gouty arthritis. A relation between gouty arthritis and ganglion cyst, sorry.
Gangrene.
Yes, please.
Why are you relating gangrene here? Do you know what causes gangrene?
Because normally ganglion cyst normally forms at the joint. That's why I wanted to know whether they're producing.
Listen, gangrene cyst may form when there has been a cutoff of blood supply to an area and the tissues die from anosmia or from ischemia. And when the tissues die from ischemia, those cysts form the gangrene cysts. So it has no bearing with what we are doing here as gouty arthritis. Are you with me?
Okay, sir.
There's no bearing, there's no relation. Clement.
Yeah, brother. Yeah, what's up?
Clement, unmute your microphone and talk. Okay, if you are not talking, Samuel, Samuel, you can unmute your microphone and talk.
Yes, thank you. Yes, thank you. Please, I want to find out
Okay,
whether
sir.
a patient with gout, is it advisable to give them aspirin and why?
Your voice is far. Your voice is far, Samuel.
So I'm not the one who is speaking. Here is Samuel. So I think my other colleague was asking about ganglion cyst. The cyst that usually comes at the wrist. That nerve swelling that happens just at the wrist. Is not. He didn't say gangrene. He was asking about ganglion cyst.
No, what
Totally,
he said, I'm not.
Okay.
Is it related to what we are teaching? You may mention something different from what we are. I didn't even get the word well. I thought you
Yeah.
were saying gangrene or something. I don't know.
No.
This is not related to what we are teaching. Do you understand?
Yes, I get it, but I also don't know the relationship between the ganglion cyst and then
So
the
why do
gout.
you relate ganglion cyst to gouty arthritis? Look at the pathophysiology of the development of this condition. So there's no relation.
Thank you, sir.
Okay. Yeah, so Annabelle, those who have, Samuel is not, your microphone is still muted. Annabelle, let's hear you. So we can move on to lower back pain.
Please, I want to know if starvation can trigger someone to get gout.
If what?
Starvation can trigger someone to get.
Definitely. We mentioned it. If you starve, you are not eating, you are not drinking. So the body keep accumulating waste. And once you don't drink to flush the body of this excess waste, definitely there'll be accumulation of these harmful waste. And this can lead to tophi accumulation. That is one of the major causes. Yeah.
Thank you, sir.
Okay. So I think we can move on to lower back pain. So lower back pain, this occurs at the lumbar region, the lumbosacral area. In fact, a lot of people have problems at the back, and it's coming from this lower back pain as a result of bad posture. Some of you may be having your farms, you bend over the period from morning to evening, you are planting something, you are trying to put something in the soil, you bend, and you do these farm practices. And once you bend, remember you are working against or destroying the natural curvature. The natural curvature is that the lumbar area is supposed to go inward and curved out to form the sacral area. So once you bend, you are trying to expand and increase the space between the lumbar or the intervertebral disc at the lumbar region. And if you keep on doing this practice over the years, this is going to affect you at the back. Sometimes people stand or sit with a very bad posture, and these are going to affect you in the future. Some people still keep on disturbing the class, and we keep on warning you. Okay. So most lower back pain is musculoskeletal. Other common causes are degeneration and diseases. So degeneration as a result of aging and bad posture. Because of bad posture, your intervertebral disc may become degenerated. And once it's degenerated, the bone comes to direct opposition, and the bones will be communicating directly without any intervertebral disc. So there's a disc disease as a result of bad posture and bad practices. Risk factors for lower back pain include, so here, if you develop lower back pain, then one of the risk factors here is obesity. Definitely once, as one lady said, there was an overweight and the lady sat down and said, let me cut off my carbohydrate diet. Let me be on vegetables and protein. It's not easy. If you are very hungry and they give you vegetables and protein to eat, you may throw it away because you want the real food to eat. So it's not easy doing that. You need a very mental toughness to go through that kind of training. So obesity here can put so much strain at the back, you can develop lower back pain. poor body mechanics. This is one of the outstanding causes. Poor body mechanics can come as a result of working, as a result of certain occupational activity that you may be doing over the years. That at the later age, it may affect you. Some people who have been farming over the years, during their later ages, they cannot stand upright or straight. They stand there when they walk, they go about bending over the year because they've been bending over the years. So once they age, that posture becomes permanent and they cannot stand upright. Heavy objects. So those who are lifting heavy objects, the weight presses on the intervertebral disc, and definitely there could be disc diseases or this distraction. Lack of exercise or physical activity. So here, if you are not exercising, you are putting on weight. If you are not exercising, the joint becomes stiff. So here we advise that exercise and physical activity takes its course to make sure that the joint becomes flexible and there's movement, free movement at the joint. You control your weight and you don't put so much strain at the back. So the signs and symptoms here, we are reporting lower back pain, and it may radiate to one or both thighs or legs. So the pain may start at the lumbar area and may descend to the lower limbs. When I'm teaching this course, I always use a case study I had that was a remarkable case that I handled. There was a woman around 65 years. So all of a sudden, this woman started experiencing severe pains at the lower limbs. And this woman started getting swelling for both lower limbs. There was so much swelling. If you press on the foot, there is a indentation. So there's spitting edema. And at a distance, every clinician might think that this woman is having kidney problem. So the sons took her to Konfanoche for kidney assessment. It came that the kidneys are healthy. There is no problem with the kidneys. But the two limbs are very swollen and with pitting edema. So much pain she cannot walk. You have to lift her. So there was cause for alarm. What is really happening? So one of the sons is a reverend father who approached me because we worship together. And then he discussed the condition with the mother's condition with me. So I said we have to take the woman through radiological investigation. So we first took X-ray. There was no clear information. We went about to take the CT scan, and then we even took the MRI. And the report came, it was that there was a gap, a very big gap at the lumbar area, which has affected the nerves, and the nerves communicate to the lower limbs. So there was poor nervous innervation as a result of pressing on the lumbosacral nerves. So the other children said we should take this woman for surgery. So they were preparing to go to Konfanoche to pay over 40,000 Ghana cedi for surgery to be done. So the reverend father, who is one of the children, called me and said, this is what they want to do for the mother. And I said they should hold on, because surgery is not the first option. If you have musculoskeletal problem, surgery is not the first option, especially at the back. So we have to consult or seek for other options. If the options fail and we have no option, then surgery could be the last resort. So we spoke to one physiotherapist at one of the hospitals. I don't want to mention the name of the hospital. A very young guy, very, 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 very good in terms of physio. This was around the COVID time. So he booked an appointment with this woman, and he communicated to the woman, and he went to the woman's house to have a session with the woman twice a week. He started with the woman, massaging with other activities, and gradually, as we show the investigation to the physiotherapist, he goes along with his mode of treatment. With 1 month and 2 weeks, this woman started getting better. The swelling reduced. This woman was able to walk with a stick. Initially, she wasn't able to walk at all. There was reduced, so much drastic reduction in terms of swelling. And within 2 months, the swelling has disappeared. This woman is no complaint with no pains again, and this woman is able to walk without sticks. Just 2 months, and this woman was able to go about her normal duties. So the children asked and we said she should continue with the physio. So she continued with the physio for 6 months, and this woman looks as if she has never fallen sick before. So we advise that when you have problem at the back, surgery is not the first option. Let's exhaust available avenues, options. And if we don't get resolved, if we don't get solutions, then surgery could become the last resort. In surgery, they may tamper with the nerves. And once they tamper with the nerves, the patient remains bedridden. You call the doctor and say, call the physio. Then why don't you contact the physio at the initial stages and get solutions to it? Now, rather you go in, cut the nerves, destroy some of the nerves, the patient becomes bedridden. Then when we call you, say, call the physio. Then I'll call the physio at the initial point. So these are the things we want you to be aware. Lower back pain, most of the people will just jump into surgery. Don't go into surgery. Exhaust available avenues. Speak with the physiotherapist. Let them come in to make sure that they do everything. When they ask you that we have done our best, now you can go for surgery, then you know they have given you the green light to go for surgery. So let's be careful how we manage our patients, especially the lower back, where the spinal nerves are passing with surgical interventions. Normally, it doesn't help. The prognosis is normally not that good. I won't take you far. Our own president, former President Kufuor, he had the operation done at the back, and he was okay initially, but later he started losing the balance, and now he can no more stand and walk. He has to use the wheelchair, the electric wheelchair. So associated symptoms include impaired bladder, because the nerves that descend at the lower limbs also supply the bladder. So when there's poor nervous innervation, the bladder is also affected. So you may have bladder problems or urine problems. So bowel function also be affected because the nerves for edging, the nerve for you to feel the edge, are all supplied by these lower nerves. Paresthesias, you may feel numbness and tingling sensations and reduced motor function. You cannot move at all. So diagnosis based on patient history, as we say all the time. Listen to the history the patient tells you. Do your own physical examination. Let the doctor continue with his own, and do your support this with radiological investigational procedures like X-rays, CT scans, MRIs, and then you have a definite diagnosis. So you have X-ray, CT scan, MRIs, myelogram, electromyelogram, discogram will describe how the disc space looks like, and somatosensory evoked potentials. These are all radiological investigations that can help you arrive at a definitive diagnosis. So NSAIDs and analgesics are given for pain, and muscle relaxants may be used to relieve muscle spasms. Sometimes when the nerves are affected, the muscles are also affected because there is muscle spasm because of the poor nervous innervation. The muscle becomes tensed and very tender, and they could set you with spasms. So sometimes you give muscle relaxants to relieve the patient of these pains. So you give epidural injections with steroid, and the steroid here is acting as anti-inflammatory. So epidural space, you go in steroid, and that may help decrease the swelling and inflammation. The spinal nerves could also be protected. Short-term bed rest may be indicated initially. We said don't act on the pain, rest the affected joint. Physical therapy is very important, as just mentioned. Liaise with the physiotherapy for them to come in all musculoskeletal issues. Liaise with the physiotherapist. They are very good partners that can bring solution to the table. Reduce the surgical intervention. Reduce the surgical. When there's the need, you go in for the surgery. When there's no need, don't rush for surgery. Ultrasound will also add up to the radiological investigation, heat or ice. Then wire pull and cognitive behavioral therapy may be helpful. These are all biofeedback that can be given to manage the pain. Surgical intervention may include the discectomy, that is removal of the disc if there's a problem, discotomy, laminectomy, where one of the condition President Kufuor, former president, went in for, and spinal fusion, when there's a gap they have a surgery to reduce the space, thereby doing spinal fusion. So surgery is good, but then be very, very careful before you go in. So pre-operatively, you have to help the patient to achieve comfortable position, raise the bed at least 30 degrees, let the patient flex the hips and the knees slightly, just to make sure that they have flexible muscles before they go in for the operation. Alternate the application of cold and heat, give analgesics as indicated. So teach the patient the proper use of assistive device, that the crutches, the cane after the operation. So demonstrate the proper body mechanics to the patient after the operation so that the condition doesn't recur. So you need to assess the patient's vital signs. The level of pain should be assessed. Give medication as needed or as it has been ordered. So in advanced countries, we have PCA, patient control analgesia. So here we hang it like an infusion and the patient keeps managing the pain him or herself. If there's severe pain, they raise the roller and some medication run into the patient to reduce the pain. So we call it PCA, patient control analgesia. Keep the head of the bed flat and elevated, not more than 40 degrees for at least 24 hours after surgery. Log roll the patient as indicated. Maintain activity restrictions so you don't complicate issues. Assist the surgeon with the initial dressing change, then the surgeon will order the future dressings or subsequent dressings. Dress it, so and so, dress it like this, dress it, use this solution to dress. Every surgeon has a way of going about his or her dressing. So follow the surgical interventions or surgical instructions to dress the wound. So monitor the patient's intake and output to make sure there's no dehydration. So surgical wound drainage or dressings should be monitored, and then do site inspection or site care dressing changes. Make sure the wound is healing as indicated. So you monitor the drainage and the bleeding or spinal fluid leakage, very, very crucial. If the surgery is done at the back, make sure that there's no CSF leakage. You have to assess the patient's motor and neurological functions or nervous functions after the operation. Has the nerves been affected? Are the surgeon affected or touched on any of the nerves? Is movement a problem? So check on all these. So you compare these findings with the baseline findings before the operation. Osteoarthritis. Any questions here before we move on to osteoarthritis? Okay, Emmanuel, let's hear you. Have a question. Let's hear you.
All right, so good morning. Please, with the patient-controlled analgesia, can the nurse also control it for, like, assist the patient if, for instance, the patient is unconscious or can't do it? I want to know a little bit about the PCA.
Yeah.
Thank you.
Yeah, the PCA is not given to unconscious patients. You know the name PCA, so it cannot be given to unconscious or very ill patients. Given to patients who are very acute, alert, conscious, and can manage their pain. Sometimes there's no need calling the nurse that I feel pains, you know. Over there in the advanced stages, they don't want the patient to go through pains at all, especially in sickle cell conditions. So they put these medications like an infusion on the patients, and they tell the patient that in case you feel severe pains, roll to this amount. So the patient is aware. So when the patient goes through that pain or that pain emerges, the patient rolls to that amount that has been discussed already. So PCA is given to patients who are alert, who are conscious, and who are going through severe acute pains.
All right.
So they manage their own pains. All right.
Okay. Okay.
Any other question before we move on? So let's look at osteoarthritis. Today we don't have waste so much time. We need to move at a rate that is very, very fast. Okay, so as we discussed about gouty arthritis, and we said it's an inflammatory response to tophi accumulation. Here, osteoarthritis is non-inflammatory joint disease. So this is non-inflammatory joint disease. Osteoarthritis is non-inflammatory joint disease. So I'm keeping on mentioning it because in the examination, students get confused about osteoarthritis, gouty arthritis, and rheumatoid arthritis. Osteoarthritis is non-inflammatory joint disease and is characterized by degenerative changes in the articular cartilage. It primarily affects the weight-bearing joints in the hips, knees, and the vertebrae, but may also affect the ankle joints, the shoulders, wrists, fingers, and toes. So osteoarthritis affects more than 50 million Americans because they are always overweight. They eat beyond their boundaries and they put on weight. Once you put on weight, it is the articular cartilage, it is the hyaline cartilages, it is the joint that is going to be affected. Because once you put on weight, any weight-bearing joint is going to be affected. Any weight-bearing joint. So the weight-bearing joint here, we talk about the hip joint, the knee joint, the vertebrae. They are the primary weight-bearing joint. Others may include the ankle joint, the shoulders, the wrist, the fingers, and then the toes. But the primary weight-bearing joint are the hip joint, the knee joint, and then the vertebrae. So these are conditions that is non-inflammatory, but can arise as a result of degenerative changes to the cartilages that prevent the two bones from coming into direct acquisition. So the articular cartilages are involved. I'll show you pictures of the disease. So here you are talking about reduction in weight, reduction in weight, reduction in weight. That is where you fall on one of your contributions where you said a lady decided to go off calorie food and be on vegetables and protein food. Here, that lady was bound for weight reduction because there's no component of carbohydrates that will put on the weight. So this is one of the conditions here we talk about osteoarthritis. So the bone or the joint on your left is very healthy, but the joint at the right is osteoarthritis as a result of weight gain. So here you can imagine to see the spots. That is where we have the exposed area. The cartilages are worn out and they are inflamed. If you look at the joint and then the picture there, yes, they are inflamed. You could see red and the sign of inflammation. So here, the same bone, a healthy bone on your left, and another healthy bone on your, no, a diseased bone on your right. Here, it is the hyaline cartilage that is given a color like sea blue. So the hyaline cartilage has become affected, has become destroyed, has become damaged as a result of weight that is pushing or pressure that is putting on the cartilage. So the cartilage starts losing its lining because of the heavy weight that is pressing on the cartilage. So the joint space here becomes narrowed and the cartilage gets decreased or destroyed. If you look at the joint space here, it's okay, it's normal, but here it's becoming narrowed as a result of destruction. So here you could see a healthy bone or joint space at the left. On the right, the sea blue, which is the hyaline cartilage or the articular cartilage, has become destroyed as a result of heavy weight that is pushing on the cartilages. So the weight has destroyed the sea blue lining, which is the hyaline cartilages, and now the two bones are becoming into direct contact, and that is giving so much pain and burning sensation. Look at the reddish. So inflammation sets in within the bones ends or the ends of the bones, and it's giving now severe pains, severe pains. So men and women, primarily those older than, so the condition affects men and women, but basically or primarily older than age 45. So by then you are putting on so much weight. So those who are older than 45 years, they are prone to osteoarthritis. But at that time, you are putting on so much weight. Osteoarthritis has been associated with aging. So you have aging. As you age, you put on weight, obesity, and there's wear and tear of the hyaline cartilage, like the pictures I showed you. However, defective gene may account for many cases of idiopathic osteoarthritis. There are some osteoarthritis you cannot assign any cause to. We call it idiopathic osteoarthritis. And here we are talking about the patient is not heavy, and therefore there's still ongoing destruction of the hyaline or articular cartilages. So once there's ongoing articular cartilage or hyaline cartilages, then you know that it is idiopathic osteoarthritis because you cannot assign any weight-bearing related activity to that particular joint. So there could be idiopathic osteoarthritis, which is more or less genetically related, previously known or previously injury or known cause. Yes, with that previous injury or no. So there's no previous injury or known cause to the disease. Then we have secondary osteoarthritis resulting from another injury or disease. So here, osteoarthritis secondary can occur as a result of another disease or another injury and affecting the joint at a remote area called secondary osteoarthritis. Both types of arthritis begin with the breakdown of the hyaline cartilage. I showed you the picture, and you saw how the hyaline cartilage was eaten away, gradually eaten away. So whether secondary or primary osteoarthritis, it begins with the eating away of the hyaline cartilage. So once the cartilage is lost, hyaline cartilage, so you break down the hyaline cartilage, covering the ends of the bones on either side of the joint. Now the line bones become roughened because the bones will be communicating directly without the cartilages. And then the bone cyst is formed. So there's a roughened ends of the bones, bone cysts start forming, fissures start occurring, spurs forms and develop on the bone surface. Eventually, the joint space is lost as cartilage loss increase, and the joint range of motion is progressively restricted. So here, with the destruction of the hyaline cartilage or the articular cartilage, the joint space is reduced, and that restricts the range of motion at the joint. So there's reduction or destruction at the joint space, and therefore the joint space range of motion is lost, completely lost. So pain in the affected joint is caused by inflamed synovium. When the cartilage is eaten away or destroyed, there's an inflamed synovium, and the inflamed synovium brings about the pain that the patient experiences. Stretching of the joint capsule or the ligament. So once the cartilage is destroyed, then there's pressure or strain come on the ligaments. So there's stretching on the joint capsule or the joint ligaments. Irritation of nerve endings in the periosteum and then the muscle spasms. So here, there's muscle spasm, there's nerve ending irritation in the periosteum. So the signs and symptoms here, there's joint stiffness. Soreness may be accompanied by dull aching pain that worsens with joint use and weight bearing. So once you put weight on the affected joint, there's that kind of dull aching pain, and it gets worse when you bear the area with weight. Range of motion is decreased, and crepitus may be felt with joint movement. Joint exhibits deformity, such as Heberdin's nose. So the Heberdin's nose are made mention of. The Heberdin's nose, that's the bony outgrowths on the distal interphalangeal joint. That's the Heberdin's nose. I showed you that finger. Yes. And then the Bocas nose. So we had the Heberdin's nose, which is distal interphalangeal joint swelling or outgrowths. Then we had the Bocas nose. The Bocas nose is bony outgrowths on the proximal interphalangeal joint. The joint may also appear enlarged and edematous. So when the node affects at the distal area, it is called the Heberdin's nose. And when the node affects the proximal, it is called the Booker's nose. So take note of them. I think I can show you pictures of the Booker's nose and then the Heberdin's nose. Let me see if I can give you pictures of them. So I think these are the pictures. You can still have a look at them. So that is distraction or destroyed hyaline cartilage. And the synovium will definitely become inflamed and start causing the pain. So this is one of the destroyed articular cartilage with the inflamed synovium. And when the synovium is inflamed, definitely it will bring about the pain. That is the pictures I wanted to show you. So the joint stiffness and so on and so forth. Joint movement, Heberdin's nose, okay. Bone spurs may press on peripheral nerves. So when the ends of the bone becomes roughened, that is called bone spurs. So there's roughened surface of the bones, and that may irritate the nerves and causes numbness or paralysis and hyposthesia of the arms, forearms, hands, legs, and feet. So the carpal tunnel syndrome and the tarsal tunnel syndrome may also result from pressure of bony outgrowths on the nerves. So the nerves, the rough ends of the nerves may irritate the nerves. So the rough ends of the bones may irritate the nerves, and that can lead to the carpal tunnel syndrome and the tarsal tunnel syndrome. Gait analysis may show a discrepancy in length, leg length, and joint alignment. So because of the pain, some people walk by bending or limping, and that can affect their gait. So sometimes the length or the leg length may be shortened, or there are discrepancies along the length of the legs and then arms. Patient history, physical examination, X-ray, CT scan, MRI, arthrocentesis, arthrogram, and bone scan may be ordered. Serologic studies, including complete blood count. You want to know if there are infections. Erythrocyte sedimentation rate to determine the extent of inflammation, creatinine levels, mineral assays, and humoral tests for immunological immunoglobulins also may be performed. So you want to see if there are immune response, then definitely it's going to be gouty arthritis. So you want to do all differential tests to come to a compromise. What's really happening? The patient may require support and stabilization of the joint with a cane. So the patient can be given a cane to use, can be given crutches to use, a walker to use, braces, or cervical collar, or traction. All these are devices that can be given to the patient to use to manage the condition. Weight reduction is encouraged in an obese patient. So once the condition has established or has, as a result of weight gain, then the primary advice to you is to reduce your weight and therefore reduce the bearings at the joint. Most heat and paraffin dips are applied as needed. Ice packs may also be used, and the massage may be helpful. So sometimes you can apply cold and ice packs to numb the area, to reduce the pain, and to make sure that the patient is comfortable in a way. So once you do that, you can also do massaging because the nerves are irritating, or the bones, the raw surface of the bones are irritating the nerves, causing spasms. So you need to massage the muscles and reduce the spasms. So you have to make sure a range of motion exercises are performed for all joints, so no joint is restricted in any movement. Balancing rest with exercise is very, very paramount. Properly fitting shoes are used to help maintain correct posture. So once you are buying a shoe, you buy a shoe. If you have size 10, you buy size 11, like the police or the military. If you are size 11, you buy size 12, like that. So you feel comfortable within the shoes. So poorly fitted shoes are used to help maintain correct posture. Properly fitted shoes. So wear proper shoes with enough space to give you the correct posture. Decrease posture on affected tissues and increase ambulation. NSAIDs, acetaminophen, muscle relaxants, and intra-articular steroids may be prescribed to relieve turners. Systemic steroids aren't used to treat osteoarthritis because it isn't primarily an inflammatory disease. So don't use systemic arthritis. The condition is primarily not an inflammatory condition. So don't use systemic arthritis because the body is not responding to anything to cause inflammation. So systemic arthritis is not primarily used. But the condition is not an inflammatory condition. It is rather degenerative changes that has occurred as a result of weight pressing on the articular surfaces of the cartilages. So studies indicate that glucosamine, so that is the medication they use to treat the joints, glucosamine and chondroitin, that is 7Cs for joint pain, is very, very effective. That is the nutrient for the joint and then the bones, the cartilages. That's the nutrient for them, the ligaments. So glucosamine and chondroitin may be useful in controlling symptoms and reducing functional impairment. Viscose supplementation, the injection of a gel-like substance into the affected space or joint may be helpful. So here, they may inject a certain gel-like substance and that will occupy the area and reduce the pain. Surgery is considered when other treatments have failed. See? So that statement should be well underlined. Should be well underlined. Make sure that surgery is considered when other treatments have failed. Total or partial joint replacement can be given to replace the destroyed joint. Joint fusion, they can do arthrodesis to reduce the jaw, to build the joint fusion, to work on the destroyed joint, to reduce the space. Or osteotomy may be performed to remove the dead tissues and then the dead bones. So these are surgeries that can be performed, but this is performed when all other options have failed to work. So nursing intervention, explain the proposed treatment regimen to the patient. Let the patient understand and be aware that these are the treatment regimen for a period. Apply heat, cold, or other ordered treatment to the joint. So if they have ordered to give or apply heat compresses, do it. If you've been ordered to apply cold compresses, do it. Any other treatment that has been ordered, just apply it. So medications like steroids, even though we are not encouraging systemic steroids, but local steroids are encouraged, like the gel that they give to the joint space, are very, very helpful. Consult the physical therapist, that the physiotherapy about exercise and other treatment. The physiotherapist will prescribe exercise that can help correct the deformity or the problem. Help the patient achieve a comfortable position using pillows as needed to promote rest. So here, pillows are needed to promote rest and to achieve a very comfortable position. So here we teach you to use our patient ambulatory aid, walkers, canes, other aids that would decrease the weight on the affected joints and help to minimize cartilage erosion. So we give you the assistive device, so you lift the weight off the affected limb so that the weight will not be on the affected limb. So the weight will be on the assistive device, so you can rest and heal the affected joint. Teach proper body mechanics to prevent injury. So now they will teach you how to stand well, how to sit well, and how to adapt a very good posture. You encourage the patient to perform activity of daily living when possible to maintain muscle strength and joint range of motion. So activities of daily living, we will make sure that we monitor you. Are you able to bath? eat, climb the stairs, fetch some water, cook your food. These are activities, sweep around. These are activities of daily living. Are you able to, or you are restricted because of the pain? Then they will know how to come and support you. Provide skin care to maintain skin integrity. Yes. So we make sure the skin is intact. So let's see if you have questions on osteoarthritis. Osteoarthritis. The questions or contributions. Okay, so let me read some of your chats. It says, the red meat, that from Robert Atakofi. The red meat, which one? So he's asking the red meat. You can see that he likes meat, so he's asking of the red meat. Any meat that looks red. You know, if you are talking about red meat, chicken is not part of red meat. Chicken is not fat. So chicken has a very nice meat. So cow meat, goat meat, sheep meat, they are all red meat. Even though pork is red, but the meat is good. So Kim was asking, say, what about intestines? I don't know. Yamadia. So intestines means Yamadia. So they are better compared to the red meat. They are good. If you don't want to take red, take Yamadia, it's better. But we say red organ meat. Red organ meat is very, very rich in purine or rich in uric acid. Then Bafo Andrew is saying, can it be cured? He's asking whether the condition can be cured. So it can be managed. If the precipitating factor is taken away, then you are free. If, for example, osteoarthritis, if you're able to reduce your weight and there's no more weight bearing on the joint space, then you are okay, you are cured. But once you cannot do anything about your weight, then it remains perpetual, it remains permanent. So he is talking about ganglion cyst. So Esther is saying he means ganglion cyst. I don't know, it has nothing to do with the topic we were teaching at gouty arthritis. Your ganglion is a nerve, and once the nerves become infected, they can form a cyst. So that is so here, neuritis rather can lead to ganglion cyst. Inflammation of the nerves can lead to ganglion cyst. Or infection, systemic infection can also affect the ganglion and can develop into ganglion cysts. So Letitia says sometimes I feel itchy at my finger joint and I have been scratching it. Sometimes it forms, sometimes it forms something like blisters and it's painful. So this one could be a skin reaction. So you consult a dermatologist, and therefore you can have solutions to it. It may not be a gouty or osteoarthritis. No. So frimpong. 20. You see what some of you are doing. It's not good. It's not good. If you intentionally try to disturb the lectures, it's not good. If not intentional, how do you do this? Have your private conversation in a class? Please. We are exercising so much constraint not to remove you from the class. Please try and discipline yourself a bit. Your private conversation is your private. It's not meant for the whole people. Over 500 students are here. Then everybody should listen to your private conversation. It's good. Please advise them, please. Frimpong Bafo is saying, please, how do we replace the lost synovial fluid? The synovial fluid is produced by the body. Once it is lost, it is lost where? It's not lost, it's infected. So you treat with antibiotics, like you inject the joint with antibiotics to treat, and sometimes systemic antibiotics, and the body will repair itself. So once you treat the infection, the fluid is produced from the blood and from the body fluids. So we don't have a place where we replace synovial fluid. The body produces it and store there to function. So once it's infected, we treat it, and then new ones appear. So pork, I say that pork could be one of the red meat, but then according to research, they say pork is a very good meat. So the fat there is a very good fat, but not to relate you to uric acid. If you are trying to avoid uric acid, pork too is red, and once it is red, it contains some level of uric acid. So that is what we say. We said in terms of fat, then the fat from the pork, they say, is a very good fat. So that is it. Okay, so Innocence, I don't know what Innocence was talking about. It's meniscus differential diagnosis to osteoarthritis. I don't know what. And then Authentic is saying, what are you eating? I'm hungry. I'm not eating, no. I'm also hungry. Yes. Then Jasper, pork meat is approved. Thank you, sir. I'm not saying go and take pork meat too. I'm saying that in terms of fat, they are saying the fat is good. But in terms of uric acid and purine, please, it's still red meat. And go by the word red meat and organ meat. Avoid them and avoid osteo or gouty arthritis. Anyway, we have some 15 minutes to go. We can mention or do something on osteomyelitis. So osteoarthritis or osteomyelitis. So once you hear myelitis, it's telling you there's an infection. So here it's an infection, or it's an acute or chronic infection to the bone and bone marrow. Always what we pray against is that the patient on the ward do not get the bone infected, because treating infections of the bone is very, 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 very difficult. However, infection to the tissues, the flesh tissues, is not serious. Once the bones get infected, it's very, very serious to treat the bone infection. So the bone may be acute form, may result from an infection in other tissues, hematogenic osteomyelitis, or from an open fracture with bacterial contamination. So you may not have an open fracture, your skin may be intact, but you may have an infection in the body where infection will be transferred from one point to affect the bones, and that will lead to bone infection. So that is osteomyelitis from hematologic point of view, blood moving the infection to affect the bones. Or you have an open fracture and you did not manage the open fracture well, infection set in, and therefore the bones also got infected. So these are two ways by which the bone can get infected. Or you may have a wound and you may be dressing the wound and you may not dress the wound aseptically. So infections transfer from the wound to affect the bones and start causing bone infection on the ward. So the chronic form may result from inadequate initial antimicrobial therapy or lack of response to treatment. Relapse occurs when the patient resistance is very, very low. So patients who get relapse and get the bone infected are those with low immune system. Low immune system. So patients who may not have adequate initial antibacterial therapy or lack of response to treatment are the people who normally show infection to the bone. So these are bone infections. If you have seen the bone infection there, so here the bones get infected. It's an infection from the blood that moves to and affect the bones. So here you could see that there was an open wound and they didn't treat the wound well, and the infections passed through the wound to affect the bones. So you could see bone infection so manifesting there. So here, osteomyelitis is seen there as well. So the metaphyseal area, you know the metaphyseal area, yes. That is the line separating the diaphysis from the metaphysis. So the metaphyseal area in long bones usually affected. That is the joint, yeah. The longer and the larger the bone, the more susceptible it is to osteomyelitis. So osteomyelitis mainly affects the longer bones, like the pelvic bone, the femur bones, the tibia, the fibula, yeah. So these long bones normally are at risk to osteomyelitis. So the bones, femur, tibia, humerus, vertebrae, all these ones are prone to infections and therefore osteomyelitis. Common pathogenic organisms here that normally causes 90% of bone infection is Staphylococcus aureus. Staphylococcus relate with the skin infections and easily get to the bones and affect the bones. Osteomyelitis, so here we have 90% Staphylococcus aureus. The rest of the 10%, we have the Streptococcus pyogenes, Pseudomonas aeruginosa, Escherichia coli, Neisseria gonorrhea, Haemophilus influenzae, and Salmonella typhi. These organisms take about 10%, but 90% is by Staphylococcus aureus. Once the pathogens locate the metaphysis, that is where the infection starts. They grow and reproduce until they have formed a mass. Leukocytes help ward off and localize the infection. Bone cells in the area die, and purulent matter spreads along the bone, eventually penetrating through the bone tissue to the skin surface. So here, they start moving, localizing along the bone at the metaphyseal area gradually, and then eroding themselves, forming a colony. Then the leukocytes will break over the wall and become localized. Then the bone cells, like the osteocytes and then the osteoid, they all die. Then the infection takes over, start producing purulent matter and affects the length of the bone. So bone infection, prevent it. Once it occurs, very, very difficult to manage. So here we may diagnose by taking the patient history. We can do bone scan, MRI, physical examination, X-rays of the involved bone are taken. Culture of the drainage. So once there's a drainage, you take a swab and take the swab to microbiology for them to identify, is it the Staphylococcus aureus, which is 90%, or the Streptococcus aeruginosa, or pyogenes, Escherichia coli, Neisseria gonorrhea, or which one of them, or Salmonella typhi. So you know the treatment that will be given alongside. So do culture, the WBC count to show the extent of the infection, ESR to show the extent of the inflammation. Antibiotics is given IV in higher doses after the blood culture are taken. Larger doses because the bone is supplied by a very limited amount of blood. And therefore, if you don't increase the dose of the medication, at the end, very little amount of the medication will go into the bones to treat the infection. So the blood supply to the bone is already limited. And therefore, if you want the antibiotics to get access to the bone, then increase the dose. And therefore, you can get the medications there. So aspirin or acetaminophen is given to control the fever and the pain. When there has been a break into the skin, tetanus tozoid or tetanus serum is given if the patient has an open wound. Then because the organism forbids oxygen, hyperbaric oxygen treatment at twice the atmospheric pressure for 2 hours a day, up to 6 times per week may be prescribed, because once we expose the area to oxygen, the organism is not comfortable. So the organism dies with so much oxygen pressure. After antibiotic therapy is completed, the bone is surgically scraped to clear away the dead bone, and residue of infection is taken away. Bone graft may be used to aid bone healing and prevent fractures. So where the inflammation has occurred, where the osteomyelitis has taken place, they will do grafting because that area has a reduced density. Because of the inflammation, the area has lost its density. So the least pressure you exert on that area, there are bound to be fractures. So after the healing, you do bone grafting to make sure that the area maintains a thickness and its density. Tubes or catheters may be inserted to flush the site with an antibiotic to clear any residual organisms. So you insert fenestrated tubes so that you can keep on flushing the area in case there are residual infections that can continue with the infection. You flush them with antibiotic therapy. An external fixator may be applied, placed above and below the osteomyelitic site. Here, the external fixator is to hold the bones into good apposition so that no pressure will be exerted at the osteomyelitic site. So this is to decrease the possibility of bone fractures. Surgery to drain the infection may be very, very necessary. Immobilization of the affected bone may be necessary using a cast, which is the POP, or a traction or bed rest. Any of these could be applied. So here, as a nurse, you need to monitor the type and amount of pain to determine the disease status and to what extent and what medication or analgesics should be given. Give antibiotics and analgesics, tetanus tozoid or tetanus serum as prescribed. Give IV fluids to maintain hydration and to improve circulation because blood to the bone is limited and therefore you need to improve the circulation. Perform neurovascular checks that the nerves and then the blood flow and monitor vital signs. Use strict aseptic techniques when required because once you make infections available, it's difficult to treat. So address the wound aseptically. The patient is more susceptible to additional infection or nosocomial infections. So be careful you do everything aseptically. So if help the patient achieve a comfortable position to relieve pressure on the affected site or tissues I have talked about, don't exert pressure because the bone density is light after the osteomyelitis. So you have to encourage the patient to perform range of motion exercises for unaffected tissue and joint to maintain strength. So don't put your weight on the affected side because it doesn't have so much strength to bear your weight. So always put the weight on the unaffected side. Teach the patient how to use the ambulatory aid, if there's one, like the arm's length. Discuss concerns about the length and types of treatment. So bone treatment takes a longer time. So let the patient and the relatives become aware so that they can cooperate with you. Provide and encourage diversional activities to help maintain patients' positive outlook. So make sure the patient get the best of treatment. Psychologically prepare the patient mind for how long he's going to be on bed and the diet the patient should take to facilitate and accelerate the healing process. And therefore, personal hygiene, very, very important. You learned that staphylococcus and the staphylococcus takes about 90%, and the streptococcus takes the rest of them take 10%. So make sure that you maintain very healthy personal hygiene. Therefore, you avoid these infections. Okay, so next week, God's willing, if we're able to meet, we discuss or talk about osteoporosis and some other conditions. It's possible we may finish musculoskeletal next week, God's willing. Yes, Shadrach.
Hello, sir. Sir, please, I have a question concerning the treatment outline. I learned that we're talking about sometimes the fluid may be drained. So I learned that sometimes it may not be drained. Then the infection may extend into the medullary cavity and sometimes under the periosteum through into the adjacent soft tissues.
Yes.
Hello, sir.
Yeah, we are listening to you.
So sometimes, because of that, it may form abscess, which may contain in the dead bone tissue called sequestrium. Yes. Because of that, they do not easily liquefy and then drain. As a matter of fact, it collapses and it may form what we call involucrum around a new bone form around the sequestrium, which we can do a procedure called sequestromy around it for it. So I wanted to know how does, yes, sir, sequestromy. How does that for if in case it does not drain, because we're talking about we should drain it, do a surgery to drain it. So in that process, and it forms like this. Thank you, sir.
Yes, so that is the reason why you should insert fenestrated tubes to keep on flushing with antibiotic fluids to remove. It's because we want to avoid what you are talking about. It's a complication, and it's because we want to avoid complications from occurring. So we keep on flushing with antibiotic therapy to make sure that the residual infections are flushed out so that those complications cannot develop and form for you to go through sequestrectomy. So we flush to make sure that residual infections are flushed away, including systemic antibiotics. That is what we do. So to prevent all the complications, we make sure that fenestrated tubes are inserted and keeps on flushing and flushing until we see healing of the bones taking place.
Okay, thank you,
Noah.
Sir.
Thank you, Noah.
Please, sir.
Yes,
I want to understand.
Yes, Noah, in 1 minute, we will be ending there. So it may cut momentarily. So once we are cut, then I say goodbye to you. So
please,
you can keep on because
I just want to know if, as you are saying, we have to give antibiotics in high doses. But in the case whereby the healing is going to take long and you are giving high doses, are you not putting pressure on the kidneys as well as the liver?
Yes. So before this treatment starts, they will do the kidney function and then the liver function test. They will note all the enzymes and then the chemistry of